Hello, and thank you for joining us to learn more about models that shape better care. I'm Dr. Terrence Cescon of Berks Hematology Oncology Associates in Reading, Pennsylvania. I'm here to talk today on behalf of the ACCC, talking about issues associated with drug resistance in chronic myeloid leukemia. Tyrosine kinase inhibitors, or TKIs, are the first-line treatment for CML. Imatinib is generally the TKI of choice. Most patients respond well, but you'll sometimes encounter imatinib resistance. In newly diagnosed CML patients, it occurs in about 2% of patients who fail to achieve an adequate hematologic response. It also occurs in those who have been on imatinib therapy for a while in about 8% of patients. Community physicians can monitor patients for imatinib resistance. If patients fail to meet the following milestones: bone marrow cytogenetics at 6 months with having less than 95% Philadelphia chromosome positive, at 12 months less than 35, and at 18 months 0% with should having a greater than 3 log reduction in BCR-ABL gene transcripts. One question that comes up is this: is there a way to confirm imatinib resistance other than a bone marrow biopsy? The answer is it is likely true that rapidly dropping BCR-ABL gene transcripts by quantitative RT-PCR are predictive of good response. But I would not at this time recommend this approach alone. I would recommend pursuing bone marrow biopsy for cytogenetics. If evidence of primary or secondary resistance is occurring, then assessing for ABL kinase mutations is appropriate, most of which end up being point mutations in the binding site. But one particular mutation bears mentioning, and this is the T315I mutation. So far, we've been talking about imatinib, but there are other CML-related drug resistance issues physicians should understand. For example, some patients are resistant to the other commercially available TKIs, nilotinib or dasatinib. Both of these agents, when compared to imatinib, are more potent and lead to more rapid drop in the Philadelphia chromosome cell line. However, they have significant toxicity. CML research is advancing, and newer agents such as azomacitaxine are coming, which is an old drug known as hominheretinine, and it is soon to come to market, which is an active drug in the T315I mutation, whereas all the other TKIs are ineffective. There's so much community physicians need to understand about drug resistance among CML patients. I'd like to leave you with this final thought. There are many patients now who do not ever require stem cell transplantation because of these new drugs. But those who have resistance, especially the T315I mutation, should be evaluated for transplant. To learn more about treating CML in the community practice setting, visit the ACCC Resource Center. Thank you for taking a moment to learn more about models that shape better care.